day. Today we are going to focus on a very important topic. Probably the most important topic we have discussed so far. I want to emphasize that you may learn these things in first year, and this knowledge is essential for you to throughout your surgery, medicine. I can't think in psychiatry, but except in psychiatry and forensic medicine, this will be helpful in all other specialties. I want to sort of emphasize that this is so important. That is why, sort of, with a very short notice and invitation, the entire research department is with us. So today we are going to talk on body fluids and electrolytes. So we thought of having this in 2 sessions. So today we are going to talk on basic physiological principles of distribution of body fluids and electrolytes in the body in a human being, how they are kept or maintained in these different compartments, and their physiological value. So the next day, so basically, how much water fluid in the body, how they are distributed, what are the main electrolytes in the body, what do they do, and what do proteins do, and how these are formed, and when we drink water, how these things get into these compartments, or in clinical practice, when we give intravenous, commonly normal saline, Hartmann solution, different types of electrolytes, and 5% dextrose, colloids, how and blood, how do they respond, how the body responds when we give through intravenous. Probably those aspects will be discussed today. Most of the time you will be asked, how does body respond after getting 1 liter of normal saline, or Hartmann solution, or 5% dextrose. So how this fluid is distributed, what does body do for this fluid, right? Those are very important. And the next day probably we will talk about abnormal distributions of fluid, like abnormal collections, abnormal distribution, seroma formation, edema, effusions, and how are we going to treat it, and how are we going to treat hypovolemia, dehydration, mainly. So those things will be discussed in next day, and how do we clinically use these different types of fluids, when to use the normal saline, when to use Hartmann solution, when to use colloids, those things. So today, mainly the physiology department and Dr. Bhagyamuridilaka will talk more, and I will also learn a lot. So with this, Pinto, can you sort of put that very basic distribution chart? We all know the majority, the main component of our body is water. 60 to 70% is water. Even some system mainly water. You and me also have water, right? So this is the very basic chart which we use. So this fluid is mainly distributed in 3 compartments. One is intracellular compartment, other thing is extracellular compartment. 2 basic compartments. And the extracellular compartment is further divided in intravascular and interstitial compartment.
So, can you ask this Shane to let us share the screen?
Shane, can you allow us to share the screen, please?
So wait, sir.
Sir, can you ask everybody whether they can hear us now? They have asked that 5 weeks ago.
Can everybody hear us? Random response is expected.
We can hear you, sir.
Yes, sir. Can hear.
Right, good. Shane, can you please allow us to share the screen?
Okay, sir. Now you can share the screen.
So this distribution basically 2/3 of fluid, the majority of this fluid is within cells. So outside cells you get about 1/3 of the fluid, and out of that 1/3 you get the main compartment of our clinical interest is blood or intravascular compartment. There the water fluid, there's about 3 liters of fluid, and the other compartment is interstitial fluid, right? Where all these cells are in this compartment. And what is this transcellular fluid, Bhagya?
Transcellular fluids are fluids that won't fall into acidical, interstitial, and plasma compartment. It might be like peritoneal fluid, pleural fluid.
Can I answer that question? Transcellular fluid is fluid that is inside, for example, the synovial fluid or the cerebrospinal fluid or the vitreous humor and the aqueous humor particularly. Things like that are in a very confined area that is outside the circulatory area. They're not involved directly in the circulation.
Okay. Is the urine in the bladder transcellular or which compartment?
We don't count that as a volume of fluid. As far as I mean, it's that's a good question. I don't know. Certainly, the transcellular fluid, the urine in the volume and is full, is quite a large volume, and it's certainly not included. Nor is the gastrointestinal secretions or whatever. They are also not included in the transcellular compartment. As far as I know, unless Bhagya has any disagreement on that, I would not include it in the transcellular fluid.
Yeah, it doesn't belong to transcellular fluid because fluid in the bladder is not exchangeable. It cannot be reabsorbed. Transcellular fluids could move back into the intravascular compartment. For example, CSF can circulate back into the intravascular compartment. But fluid in the gastrointestinal tract belongs to a transcellular compartment because it can get reabsorbed. Whereas fluid in the bladder is not.
So it's totally outside any of these compartments. Right. So
It's actually excreted material.
thank you very much for with this start deeply. Can you tell us we can understand sort of what blood does, plasma does, but what is the importance of interstitial fluid? And you see now only about 10 liters of fluid, or majority of the extracellular compartment is in the interstitial compartment. What does it do? What's the function of interstitial fluid?
Yeah, it's a fluid that bathes the cells. So the cells are surrounded by the interstitial fluid. And it is important because any substance that has to go into or out of the cell has to move through the interstitial fluid. So that it is the area through which, for example, oxygen comes from a capillary, it can diffuse out under its own partial pressure gradient into the interstitial fluid first, before it can move from the interstitial fluid into the cell, or if it's carbon dioxide, in the opposite direction. So this interstitial fluid, which is bathed in the cells, are there to maintain an aqueous environment from which the cells can get substances transported in and out of it.
So this is the media of the body.
Sorry, did you ask a question? I couldn't hear that.
So this is so all the cells are waiting in this interstitial fluid compartment, which is so important. I think from the cells come into the interstitial compartment, and cells also getting their nutrients, oxygen, other things also from the interstitial compartment. So that is the communication barrier between the blood and the cell. Is it Deepti?
Yes.
Right. So intracellular now, if we sort of look at the composition of these fluid compartments, can you sort of put the composition of this fluid compartment? So now there are protein, there are electrolytes and water in these compartments in different compositions. So, Deepti, can you roughly tell us sort of what's the importance and how they are distributed in this compartment?
Yes. So of the electrolytes, there are two really important ones that we need to think about, and that is sodium and potassium. And I'm sure all of you know that sodium is the main extracellular cation. It's a positively charged ion in the extracellular compartment. Potassium is the intracellular cation, the most important one. Yes, so this diagram very clearly shows you what those two very, very important cations are. Potassium is the intracellular cation, sodium the extracellular cation. If you look at the anions, the negatively charged ions, it is chloride. And I see it's not difficult for you to remember because sodium and chloride move together, they're together. So chloride is the anion of the extracellular compartment. And as you remember, bicarbonate is documented there because bicarbonate is a very important buffer that we find in our body. So those two, the chloride and the bicarbonate, make up the most important negatively charged ions of the extracellular compartment. Now, in terms of the other ions that are involved, I think you can see the importance of calcium and magnesium. Now, calcium and magnesium in terms of quantity are not as important as sodium and potassium. But in terms of their distribution and their functions, they're extremely important as well. So you remember that calcium has a huge number of functions in our cells. It's involved as a neurotransmitter, it's involved in neurotransmission, it's involved in exocytosis, it's involved in maintaining contraction of some muscles. So it's a very, very important cation. And there's more of it in the extracellular compartment. And the other side, you can see that magnesium, another extremely important cation, in terms of quantity, not as important as potassium, but extremely important in terms of normal cellular function. It is an intracellular positively charged ion. So you can see that as a result, overall, the positive ions are distributed in a way that there's electrical neutrality. So we talk about the resting membrane potential and the fact that there is a potential difference which is present across the cell membrane only. Overall, it is electrically neutral. So we have to have electrically neutrality between the positive and the negative ions. So we talked about the positive ions outside as sodium, inside as potassium mainly. The negative ions outside, mainly chloride and bicarbonate. But of course, there has to be negative ions inside the cell as well. And in the intracellular compartment, the is involved is this the proteins. The proteins are extremely important, and as you can see that there is of course protein in the plasma as well as inside the cell. The interstitium has very little protein. And then you can see that there are the other negatively charged substances like the phosphates and some of the other organic anions that are involved to maintain the electrical neutrality between the positive and the negative charges inside and outside. Okay, that's what I wanted to say. Is there anything else you want to ask me?
Okay, thank you very much, Deepti. So you said the main anion or cation in the within cells are potassium. Main cation outside cells is sodium, and the main anion outside cell is, though it is not an ion, the negative charge particle is protein, and main anion outside cell is chloride and little bit of bicarbonate as well. So what is the difference now? Protein plays a role. What is the main role of protein in this compartment? You say sort of the ions maintain the polarity. But as protein do? It's a huge molecule. Can't move like easily like ions. What's its role?
Right. So yes, the proteins are there and they tend not to move out of the capillary into the interstitium and not out of the cell. Mainly most of those proteins that are inside the cell stay inside the cell as well. So they're not going to be moved in any significant way across the cell membrane, nor across the capillary either. So the function in terms of fluid balance, if you're talking about fluid balance, they have the major function, as you said, is about the osmotic pressure, the colloid osmotic pressure, which is the protein exerted colloid osmotic pressure. So the colloid osmotic pressure, in effect, we think about as the pressure that enables the filtration. It is one of the most important, is one of the factors in the scarring forces in the capillary. So the colloid osmotic pressure is within the capillary, and it is a factor that draws fluid towards it. So that is a major component. I mean, of course, proteins have a large number of different functions inside the cells. I mean, obviously, all the cellular functions are performed by the proteins. But in terms of the colloid osmotic pressure, we really think about it in terms of what is happening in the capillary. So it is the factor that maintains, it's one of the most important factors that maintains the fluid, the filtration of fluids in a capillary. Are we going to talk about fluid filtration later on in this discussion?
Yes, later.
Okay. Anything else you want to ask?
Bhavya.
Yeah, if I could add to what Deepti said, the proteins, intravascular proteins, they exert a colloid osmotic pressure. And they play a role in discharge forces. Because that's one of the determinants of the filtration pressure, hydrostatic pressure gradient minus the osmotic pressure gradient. In addition to scarring forces, now they talk about endothelial glycocalyx, which is a surface layer on the endothelial cells, and that is thought to play a very important role in the exchange of fluid between the intravascular compartment and the interstitial compartment. And based on that theory, the oncotic proteins which exert oncotic pressures within the capillaries prevent or tend to hold back the water in the intravascular compartment, but has a very minor role in reabsorption of water from the interstitium into the intravascular compartment. The belief is that the major route of return of interstitial fluid into the intravascular compartment is via the lymphatics, not because of the oncotic proteins. So that's one reason we try. We used to use a lot of albumin in patients with edema, hoping that by increasing the oncotic pressure, fluid gets absorbed. But it does not. It can actually increase the filtration because by increasing the protein concentration in the intravascular compartment, you increase the filtration pressure. The hydrostatic pressures will increase. You might increase the edema formation unless lymphatic flow also increases simultaneously.
Thank you very much, Bhagya, for that clarification. So we have so far learned now most of our body consists of water, about 60%, and this fluid is mainly distributed in 3 compartments or mainly 2 compartments within cells and outside cells. The intracellular compartment has about 2/3 of this fluid. 1/3 is in the extracellular compartment outside, and the extracellular compartment is further divided into vascular compartment or your plasma blood and interstitial compartment, which is very important as we said all cells are bathing in it, so all cellular functions are related to the composition of interstitial compartment. So about 25% of the cellular fluid is in vascular and rest is in the interstitial compartment. So that is the distribution of fluid in percentage. Then the main electrolytes in these fluid, in these compartments. Outside cells, the main cation is sodium, main anion is chloride, bicarbonate also. Within cells, main cation is potassium, and the negatively charged main particle within cells is proteins. So there are magnesium, calcium, other electrolytes as well, but they are very important in cellular functions rather than the polarity of these compartments. Right? And we talked about distribution of protein. Right? So mainly protein is in intracellular compartment and the vascular compartment. Am I correct? There's not much protein distributed in the interstitial compartment.
The protein in the intestine, there is protein in the intestinal compartment, but the intestinal compartment is not a liquid compartment. It is like almost like a gelatinous matrix. So that's a difference between the proteins that you find in the vascular compartment and the intestinal compartment.
Okay, so it is trying to tell us sort of the Starling process and this, how does this fluid getting filtrated and distributed in this compartment, and it is a dynamic process. Everything moves out and comes in and try to maintain the polarity as well as the osmolality and the volume status, more or less steadily in each compartment. Before that, can you tell us something about what is osmolality of a compartment, and is it different between these 3 compartments? Are we getting any response from physiology department? Oh, they are not there.
Okay, osmolarity. Sorry, if Bhagya can talk.
No, go ahead. Go ahead.
Well, osmosis is the pressure under which water can move, and as you remember, water moves according to a concentration gradient for water. So if they're from a high water to a low water area, so the osmolarity is the force of osmosis is what we can measure as a pressure that we can use to prevent the movement of water from one compartment or one area to another across a semi-permeable membrane. So water will move but we have to put a pressure to stop it, and that is the osmotic pressure. So there are various, there you go, there are various factors that determine the ability of water to move across a semi-permeable membrane. And these are what is here, the moles of osmotically active particles, and the different osmotically active particles are present in different compartments. So in normal, we would think of it as being made up of identical osmolarity, so that water can move from one compartment to the other and vice versa. And that is what you want, because you do not want the cells in our body to be exposed to a rapidly changing osmolarity, because if it changes, the osmolarity in the interstitial fluid increases, then water will move from inside the cell to the outside. Or if it decreases, water will move from the interstitial to the cell and cause the cell to swell. And neither is good for our body. So obviously we want to avoid that. And in order to avoid that, we maintain an osmolarity that is the same, or the same osmolarity between the intra and the extracellular compartments.
Actually, so the osmolarity of intracellular and extracellular compartments are more or less same. What is the figure like? It's about 300 or 296 if I remember. I'm not 100% sure. It's about 300, 296. So all three compartments has the same osmolarity. So that is, what are the components which maintain this osmolarity? Does protein also contribute for the osmolarity, or it is only the electrolytes?
Proteins contribute, but it's not known as osmolarity. It's osmotic pressure exerted by proteins, but it's osmotically active particles. So particles like glucose, urea can also have an effect on osmolarity. Mainly intravascular compartment is the electrolytes plus metabolites like blood glucose and urea, depending on, but it's mainly the electrolytes, especially in the intracellular compartment, it's the electrolytes.
So the osmolarity or osmotic pressure of different compartments, or more or less it is same, it is maintained by electrolytes.
And the movement of water.
Yeah, and this osmotic pressure is kept constantly, or sort of more or less constant, by movement of water. It is a passive diffusion. It's not an active process.
Movement of water.
Water, yes. Water diffusion is passive. So electrolyte doesn't move, but water moves. Is it?
Electrolytes move. Electrolytes move according to concentration gradient. So you look at the electrolyte composition.
Yeah.
Electrolyte composition in the intercellular compartment and the intravascular compartment, that is the extracellular compartment, is almost the same. The electrolyte composition between the extracellular compartment and the intracellular compartment is different, but the osmolarity is the same. What moves is water. Water moves with sodium and chloride, and sodium moves because of a interstitial sodium moves because there is a concentration gradient between the extracellular compartment and the intracellular compartment. So when sodium moves, chloride moves, it drags along water with it. The concentration gradient is maintained by the action of the sodium potassium ATPs and other pumps, which move sodium against the concentration gradient from the cell, the interstitial compartment. The potassium against the concentration gradient from the interstitial compartment into the intracellular compartment. So the ions tend to move along the concentration gradient passive along the channels, the proteins like sodium, potassium, ATP, the cell membrane channels, move the electrolytes against concentration gradient. That's an energy required process to maintain this the concentration difference. But generally, water moves along with sodium.
I think that's clear. So electrolytes play a major role, and proteins also play a major role to maintain the polarity as well as the fluid volume in these different compartments. Deeply, can you tell us sort of how these sort of transported across different compartments and how they are getting back into the other compartments? What are the Stalin forces and how does it work?
Okay, right. So there are two movements that we need to think about. If you're talking about water, water has to go from a capillary to the interstitium and from the interstitium into the cell. So there are two different mechanisms or two different methods by which this water can move. So the first movement that we'll talk about is really the movement across the membrane, and that's a cell membrane. So you all remember that the cell membrane is a lipid bilayer. It is fatty. So water and fat don't mix. So in order for water to move by osmosis, it is a passive process from a higher to a lower water area. So water will follow. As you heard just now, sodium ions will move, water will move, follow it. The osmotic pressure will be altered. So therefore water will move. But in order for water to move, the cell membrane needs a channel. You can think of a channel like a gate that is open all the time. So your neighbor can come in, so can a thief. Now, anything can come in through that channel. So just like that, there are water channels, which you remember are called the aquaporine channels. So off the top of my head, I don't remember all the names on all the distribution of the aquaporine channels. But these are like little holes that are in the wall of the membrane. And what it allows is the water to move. And it is a passive movement from a higher to a lower level. And it doesn't select. It doesn't say, you're the water molecule I want to move, but not the other water molecule. It doesn't select. It just lets all the water go through. But there are different types of aquaporins that are found in different cells. Some cells have aquaporin 1, some will have aquaporin 2, and so on. Okay? So what you need to remember is that all the movement across the cell membrane, membrane transport of water involves those aquaporine channels. The second movement we need to think about is what happens between the capillary and the interstitium. And those are the Stalin forces. So that is the balance between the hydrostatic pressure and the colloid osmotic pressure in effect. Okay, so Dr. Bhagya mentioned the proteins. The proteins don't move. So we don't, so those are the things that we are going to think about in the Stalin forces, the protein inside the capillary that stays in the capillary, and the hydrostatic pressures. So you remember that movement of water from the circulation into the tissues only can occur in that microcirculation of the capillary. So the movement only happens out of the circulation into the capillary, from the capillary into the interstitium by those hydrostatic, the balance between the hydrostatic and the colloid osmotic pressure, and that can be called filtration as well. We call that filtration. We can also call it bulk flow. Whatever you call it, that is the process, the balance between the hydrostatic and the colloid osmotic pressures. It's something important to remember because those are pressure differences that determine the movement of water across the capillary, and the osmotic pressure difference that allows the water movement across the cell membrane from a higher water to a lower water area, but always using the aquaporine channel across the cell membrane.
So like DT said, the movement of water between the intravascular compartment and the interstitial compartment is explained by the Starling's force. Important determinant of this movement is also the capillary permeability, which is given a position depending on tissue. So there are capillaries which are totally impermeable. Example, maybe the the blood-brain barrier. Then there are capillaries which are adapted to allow a lot of fluid to move, for example, in the glomerulus. Then you have capillaries which are in between, and those are the capillaries that we typically describe. Those are in the muscle, skeletal muscle. So, in addition to the what about alveoli? Yeah. So, alveoli, it's not only the capillary permeability, the alveolar epithelium also plays a role, but there is also a mechanism to remove whatever fluid that moves into the interstitium very, very fast. So, the lymphatic drainage becomes very important in the alveoli.
So basically, we were talking about two main mechanisms in the fluid transport or exchange between these compartments, and between vascular compartment and the interstitial compartment, it is mainly the capillary permeability and the Starling forces. And cells from the interstitial compartment to the cell wall doesn't allow free transfer like between capillaries and interstitial compartment. So that is mainly covered by these different channels and the osmotic pressure. Osmolarity gradient. So a little bit about fluid exchange between at the capillary level. Right? So like I said, sort of the fluid is drawn out from the capillaries and the equal amount is sort of drawn back into the vascular compartment. How does it happen? And what is the main force, or what are the forces which draw out and draw in at this level?
Initially, we used to explain all this with the Starling's mechanism, movement of water from the intravascular compartment into the interstitial compartment.
We will initially highlight that students are more familiar with the Starling forces.
So the pressure, that's a filtration pressure gradient. The filtration pressure that favors or pushes water out of the capillaries is the capillary hydrostatic pressure. And the oncotic pressure exerted by proteins in the interstitial compartment. That is those are the forces that drag water or push water from the intravascular compartment into the interstitial compartment.
Hydrostatic pressure means like blood pressure at the capillary level. So blood pressure, the main arteries are higher, and when it is sort of come to the capillary level, it is lower. That vascular pressure is called the hydrostatic.
So that hydrostatic pressure can be regulated by the constriction or dilatation of the arterioles or the precapillary sphincters. The other force which opposes the filtration of water is the oncotic pressure within the capillaries exerted by the plasma proteins, and the hydrostatic pressure within the interstitium, which opposes filtration. So the difference between these four forces, that is a net filtration pressure, that determines the direction of flow, in addition to the capillary permeability. Once the fluid gets into the interstitial compartment, the fluid will move via the lymphatics back into the intravascular compartment. So any obstruction or any congestion to the lymphatics will lead to accumulation of fluid in the interstitial compartment. or if the filtration of fluid from the intravascular compartment into the interstitial compartment exceeds the capacity of the lymphatics to extract fluid, that will also lead to the formation of edema.
What are the clinical conditions which we get more fluid in the interstitial compartment? We see a lot of clinical scenario, and what are the basic physiological basis behind that?
I think BMA, I say BMA is the sort of the external representation of the changes in this transmission between the two compartments. So edema can be seen in inflammation, basically inflammation due to trauma, or else when there is a change in the oncotic pressure, as we mentioned, in the intravascular compartment due to a reduction in the proteins that we get. So basically what happens is the regular outflow at the arterial end and the inflow at the venous end gets disturbed when there is a either there is an increased permeability of the capillaries with increased fluid flux at the arterial end with reduced more than what the venous end can absorb, or when there is a change in the oncotic pressure, as we mentioned. And also if there is high pressure at the venous end. So as the Starling forces, the diagram mentions there is a low pressure at the venous end, and the hydrostatic pressure, if the hydrostatic pressure increases due to a block in the venous flow, also this influx can be reduced, and then there is accumulation of fluid in the interstitial space. So as we see in inflammation, where the capillary permeability increases due to various inflammatory mediators, you can see edema because there is a disturbance into the Starling forces. And when you have conditions like hypoalbuminemia, you have accumulation of fluid in the interstitial space because there is lack of oncotic pressure. And also when there is venous obstruction due to venous hypertension, or there is a mechanical block to the blood flow in the veins, you could see there is lack of absorption in the venous cells. So there is accumulation of fluid in the interstitial space. And when this happens in the lungs, you can see there is fluid accumulating in the alveoli, and that has grave complications out there. It happens, for example, in the ankle, right? You can see ankle edema when this happens in the knees, but it happens in the alveolar circulation, the pulmonary circulation. You have fluid accumulating in the alveoli, which has more grave complications because it affects the oxygen transmission between the blood and the alveoli. So these are some of the common instances where you could see a disturbance into the Starling forces, and the consequences we see clinically.
So far, I'm sort of summarizing over and over because it's so important topic. So far we have discussed that focus the most abundant component in human body. That consists about 60%. That vary different sexes and ages as well. They getting older, they become more dry. And this is distributed mainly in 3 compartments. Within cells, called intracellular compartment, the majority or 2/3 of the fluid is in the intracellular compartment, and 1/3 is outside cell, and it is subdivided into intravascular compartment. That's about 1/4 of the fluid in outside, and the most of the extracellular fluid is in the interstitial compartment, which is a very important compartment where all these cells are bathing, and sort of their environment is the extracellular interstitial compartment, and cells get their nutrients, everything from that, and they put the unwanted thing into the interstitial compartment. And then we talk about how this fluid is maintained, and there's a dynamic process. The fluid shifts from one compartment to the other, and but their volume and their osmotic pressure is maintained more or less within constantly. So this is done with the electrolytes in these compartments and the proteins in this compartment. And the main electrolytes outside cells, so it's a cellular compartment. The positively charged ion is sodium, negatively charged ion is chloride. Within cells, the most abundant positively charged ion is potassium, and negatively charged ion, negatively charged particle is protein. In addition to that, sort of magnesium, calcium, other electrolytes also play a role, not mainly to maintain osmolality, but for other cellular functions. Then we were talking about how this cell, now there are three compartments, how fluid moves. There are two main mechanisms. Now, cell membrane, across the cell membrane, the fluid shifts from interstitial compartment to the intracellular compartment based on the osmolality or osmotic pressure and through channels. And electrolytes move with water, and the electrolytes are kept constantly by moving in and out of these electrolytes by different mechanisms. Then fluid movement from vascular compartment, from blood into the interstitial compartment, is basically based on what is called Starling forces, which is mainly the capillary permeability, which is influenced by capillary permeability, hydrostatic pressure, and oncotic pressure. So fluid grows into the interstitial compartment due to the net effect of these forces, right? And fluid drawn into the vascular compartment in addition to these forces by the lymphatic channels. And diseases, different diseases occurring in the which affect the hydrostatic pressure, which affects the capillary permeability like inflammation, which affects the lymphatic drainage, which leads to abnormal collection of these fluids in different parts of the body, right? Which leads to different clinical scenarios. As Thomas said, you can get edema, you can get ascites, you can get pulmonary edema, right? So different clinical concepts due to these. It is important to understand these basic mechanisms to understand or to relieve this abnormal fluid collection, right? So this is the trust of fluid and electrolyte balance in the body. But from with this knowledge, physiology department is with us, I suppose. So what happens if we drink? Suppose I drink about a liter of water. How does it distributed, and how long will it take distribute within the compartment which we have discussed so far?
Do you want me to answer?
Yes, Deepthi.
All right, okay, right. Okay, so water, as you drink it, it has to be absorbed from the gastrointestinal tract. And as you remember, it starts getting absorbed fairly early in the upper parts of the gastrointestinal tract as well. But it is always difficult to be, Bhagya may be better able to answer that question. But there is a there is a time lag between drinking the water and it entering our body fluid compartments directly. But it's not a huge, long delay. So as it is absorbed, and we assume, if you assume that 100% of it is absorbed, so all 1 liter of it is absorbed, it will distribute in the body fluid compartments, and it is proportionate. So you remember that first slide that you saw where there was a 66% of water in the intracellular fluid and 33% in the extracellular fluid. So the water that you drink
Are you with us? We can't hear you. Students, can you hear me?
So ask from Shane. Shane,
Shane, can you hear us? Lost the connection.
Recording करना.
Sorry, I got cut off. Can you hear me now?
Can you hear me now?
Yes, yeah. So the liter of water will be distributed 2/3 into the intracellular fluid, 1/3 into the extracellular compartment. And in the extracellular compartment, of the 1/3 that is distributed there, the 333 milliliters or so, 75% will be in the interstitial fluid and 25% will be in the circulating compartment, in the plasma. So you can work out what how many milliliters that is, but it is not. So is that what you wanted me to answer, Sumudra, or do you want me to speak?
Yes, yes, thank you very much. Sorry for the disruption of the line.
I think it was my connection that went just now.
We can hear you.
Okay, thanks.
Drinking,
Yeah.
what happens after drinking 1 liter of water?
Yeah.
So if it depends on whether the patient is drinking voluntarily and whether the systems are, if the patient is actually thirsty and is drinking water because of that, most of the water gets absorbed. But if it's pathological and the patient keeps on drinking despite not being thirsty, then there is a risk that the osmolarity would get disrupted. The normal mechanism might get disrupted. So if the patient is well hydrated, even if the patient drinks not excessive amounts, but reasonable amounts, excess water will not get absorbed. The patient will lose it via the gastrointestinal tract itself. So this is the, if I may divert a bit, this is the advantage of giving oral fluid. The patient, the normal physiology, this normal thirst mechanism, it's almost impossible to fluid overload a patient by giving oral fluid because the excess fluid will not get absorbed. Compared to a patient getting intravenous fluid, where the patient regulating mechanisms have no control. So
If you don't force him to.
yes, if the patient takes normal amounts as required, determined by the patient's thirst, whatever is drunk is required to get absorbed, and the rest will be eliminated.
So that's good. So Bhaga just touched that sort of there are other mechanisms which govern the amount of fluid or sort of for the retain to retain fluid in this compartment other than electrolytes, oncotic pressure, osmotic pressure and all that. It said about the volume receptors and the barrel receptors, volume receptors, and the osmotic receptors. They also do play a role. and the renal mechanism to maintain the amount of fluid in these compartments. Can you tell a little bit about that at this stage, or we talk them in another?
So, hypothalamic stress centers. So, Bananos thirsty needs to retain water. In secrete more antidiuretic hormones. And antidiuretic hormones acquire increasing by increasing the number of aquaporin receptors in the collecting ducts. So a person who is dehydrated or volume depleted because of dehydration, there is not enough water in the body, the interstitial osmolarity will increase. So that applies to the renal interstitium as well. So when the aquaporin receptor normally collecting ducts and distal parts of the collecting tubular collecting ducts are impermeable. And in a patient with who's dehydrated and median secretion has increased, this leads to an insertion of these aquaporin channels into the collecting ducts. And therefore, the dilute water in the relatively dilute water in the renal tubules can move into the hypertonic or concentrated interstitium via these aquaporin channels. So that increases the amount of water absorption and tends to return the osmolarity back to normal. That is the water. But there are similar mechanisms for reabsorption of sodium. That's a renal angiotensin aldosterone mechanism. But the water reabsorption will mainly depend on this pH mediated mechanism.
Suppose now that is when we drink something.
Can I make a small add a little point just to remind the students also that in terms of the kidney in the nephron, the vast majority of water is reabsorbed in the proximal convoluted tubule, the ascending duct of the loop of Henle. So that is unregulated. Whether you have ADH or not, that water will get reabsorbed. So it's only the last 10 to 15% of the water that is in the nephron that will get reabsorbed under the regulation of antidiuretic hormone. Again, just a little point to remember that the osmoreceptors, the hypothalamic osmoreceptors, they are outside the blood-brain barrier. Normally, the brain is protected from swings in osmolarity that can happen in day-to-day life even. Because tiny little changes in osmolarity are very sensitively detected by the osmoreceptors. And these are the circumventricular organs that are outside the blood-brain barrier. So the brain doesn't get affected, and the correction happens long before any osmolarity changes can happen in the brain because of the very sensitiveness of the osmoreceptor.
Thank you very much, Deepthi. In addition to these different poses and electrolytes within the cells and outside cells, the renal mechanism and certain hormonal mechanisms governed by the osmoreceptors as well as volume receptors as well when we give IV fluids, isn't it, baroreceptors? Also indirectly control the fluid status within these compartments. Deepthi or Bhagya, whoever. So what happens if you give 1 liter of normal saline? It is a commonly used intravenous fluid and commonly used crystalloid in clinical practice. What happens if you give 1 liter into the okay, Bhagya wants you to give an answer.
Okay, is it me or?
Yes, yes.
Okay, right. Well, you remember the sodium chloride is sodium, therefore sodium is distributed in the extracellular compartment. So we are talking about that 1/3 of the body fluid compartment, the extracellular compartment. So if you give sodium chloride, it is going to be, if you give 1,000 milliliters, it will be distributed according to the quantity of the extracellular compartment. So theoretically, 75% will enter the interstitial fluid, and 25%, so 250 milliliters or so, will be added to the circulating plasma. So that is what we normally sort of, as a kind of rule of thumb, think about the distribution of sodium chloride, and that is normal saline. Yeah.
Soon after we get to the vascular compartment, everything is in the vascular compartment. Your 100 ml is in the vascular compartment. How soon or how long will it take for them to distribute into the, you said about 75% go into the extracellular compartment, interstitial compartment. How long will it take for them to go into the interstitial compartment?
Can I maybe ask the Bhagya to answer that one?
Bhagya, how long will it take?
Yeah, so if 1,000 liters of normal saline is infused into the intravascular compartment, the effect will depend on the patient's intravascular volume thickness. If you assume that the patient is normally and you're just infusing 1 liter of normal saline, that will lead to an increase in hydrostatic pressure. When the hydrostatic pressure increases, the filtration pressure increases. So fluid will filter body starting forces into the interstitial compartment until the filtration forces balance out. So when that happens, you will find that about 75% of the volume that you are infused intravenous has leaked out into the interstitial compartment. For crystalloids, this usually takes about 20 minutes. So after about 20 minutes, you will find that about 75% of the crystalloid that you have infused is in the interstitial compartment.
So Bhagya, you are telling, when I give 1 liter of normal saline to a normal person, a healthy individual, 75% or 750 will go into the interstitial compartment, and only 250 ml will remain in the vascular compartment in 20 minutes. Soon after I give it, 1 liter will be there, but in 20 minutes, only 250 or 1/4 of it will retain in the vascular compartment. Anything goes into the intracellular compartment.
So now we discussed the forces that shift fluid between the interstitial compartment and the intercellular. So for fluids to move between the interstitial compartment and the intracellular compartment, there has to be a osmotic gradient. But if you use isosmotic fluids, normal saline is not osmotic, isosmotic fluid. You have to believe it's isosmotic, but it's slightly hyperosmotic. It's 124 millimoles per liter, 308. So if you take your osmolarity as, so it's slightly high, but for the moment, let's assume it's isosmotic. Right? So if you use an isosmotic fluid and 75% of it moves into the interstitial compartment, theoretically there should not be any movement because the intracellular compartment has the same osmolarity as the interstitial compartment. But in reality, that's not what happens. The sodium does move into the cells. The sodium that you give in the form of normal saline will move into the cells, and water will be dragged along with it. But this same amount will come out. So there is no net movement of water. There is movement, but there is no net gain of volume in the cells.
So, in a nutshell, when you give 1 liter of normal saline, it will not go into the cells. So it is not a good fluid replacement for cellular dehydration. And as it is, as Bhagya said, as it is isosmolar, any isosmolar fluid will be distributed between its percentage in the extracellular compartment. So nothing will move into the cell. So distribution of fluid percentage in the extracellular compartment will govern the amount retained in that compartment. And for normal saline, it takes about 20 minutes in a normal individual. Suppose the patient comes with hypovolemia, Bhagya, following traumatic accident, has led little bit tachycardia. Will they retain this fluid longer time, or lesser.
So if the patient is intravascular volume leak, patient is tachycardic, patient is hypotensive, all indicates that the intravascular systolic pressures are low. So the filtration will be slower than in a normal volume patient. But ultimately, when the volume is restored, when the compensatory mechanisms are activated, the intravascular compartment is restored, fluid will start leaking out. In addition, if it's a trauma patient, there will be inflammatory response leading to increased capillary permeability. So that also will affect the rate of flow between the intravascular compartment and the interstitial. But you can assume that it is slower than in a patient. The movement of fluid into the interstitial compartment is slower. So it's safe to use Physiological. Actually, Physiological are now recommended to resuscitate trauma patients. That's the first line.
Okay. So it will stay in the vascular compartment longer, but ultimately only 1/4 of that volume will retain in the vascular compartment. So take home message is if you use the Physiological, so within half an hour, only 1/4 will retain in the vascular compartment. What happens now when we give, let's take a normal individual, you give 1 liter of water or 1 liter of normal saline. What does kidney do now? Now, when you give fluid, your baroreceptors, will they get excited with 1 liter of normal saline, or will they be silent? Will there be any change in osmoreceptors when we give normal saline, 0.9% normal saline? What are the effects on baroreceptors, osmoreceptors, and what will kidney do for this 1 liter?
So first, the baroreceptor. If you infuse 1 liter of normal saline into a normal healthy patient, the intravascular volume, intravascular volume will literally increase in blood pressure. This will be sensed by baroreceptors. So baroreceptor firing will increase. This firing has an inhibitory effect on the vasomotor center. Vasomotor center will be inhibited. So the patient will get vasodilated to accommodate this fluid, leading to a normalization of systolic pressure. The cardio-inhibitory center will be activated, and the patient might become bradycardic. Again, reduce cardiac output, and therefore lead to a reduction in the systolic pressure, and therefore reduction in the normalization of pressures. Osmoreceptors unlikely get stimulated because you are using isosmotic fluid. So there is hardly any activation of these osmoreceptor mediated mechanisms. Now, when the systolic pressures increase following the infusion of 1 liter of isotonic fluid, the filtration, the glomerular filtration rate will increase. So more fluid will get filtered in the filters. But since the patient is normovolemic, the renin-angiotensin aldosterone axis is not activated. So other than for the constant reabsorption of water and electrolytes in the proximal convertibule and the proximal parts of the nephron, the aldosterone-mediated sodium absorption, the ADH-mediated water absorption will not happen. So the patient will become cardiac or will increase the urine output until this excess fluid has been extracted.
You see the excess fluid in the vascular compartment, that is about 25%, or the excess fluid or the entire 1 liter is excess.
Okay, so the body doesn't have volume receptors. Body cannot sense volume. The body has baroreceptors, and until the baroreceptor activity returns to normal, all these mechanisms will be active. So might be 200 milliliters, it might be more than that, but depends on how soon the pressures return to normal. The body doesn't have volume receptors.
How long will it take for the adrenal response?
It again depends on the patient's hydration status. If the patient is normally, patient will experience volume very fast. Sometimes within an hour, even if you drink a liter of water, you will find that you need to run to the toilet very quickly, because the response is very rapid. It also depends on how active your autonomic nervous system is, how well your kidneys function, all that. But it's very fast.
So the last topic we are going to talk today, probably time runs out, and the next day, probably next Thursday or week after, we'll talk about the clinical application of this thing. One last thing, now this is what happens when we have 1 liter of normal saline intravenous. Is there any difference when you take 1 liter of Hartmann solution intravenous?
Hartmann's has a different composition. Normal saline has sodium and chloride in hyperphysiological concentration, 154 millimoles per liter of sodium and chloride. Compared to Hartmann, which has 131 millimoles per liter of sodium, some amount of bicarbonate, less amount of chloride than normal saline. In addition, it has potassium, calcium, and also lactate. So it is more physiological. And also, especially when you infuse large volumes of crystalloid compared to normal saline, normal saline is known as hyponatremic, hypochloremic metabolic acidosis, which is less marked with Hartmann. So large volume crystalloid infusion of with Hartmann will lead to less elements of cyanic concentration. But there's also bit of evidence show that large volume infusion of normal saline leads to a reduction in renal blood flow and reduction in GFR. So unless the patient is hyponatremic, where you want to restore the normal saline, the sodium concentration, the choice of fluid would be Hartmann's for intravascular volume.
I'm asking sort of the distribution. Is it similar to normal saline?
It is similar because it's a crystalloid. It's isotope.
So just to sum up, we have what we have discussed so far. And before that, I'd like to thank the Department of Physiology. I hope you will join with us next time also. And many thanks to the entire Department of Physiology. And just to sum up what we have discussed so far, the human body mainly consists of water. I think it's the 6th time I am repeating this. And it's about 60%, and most of this water is in the intracellular within cells, and about 1/3 is in the extracellular compartment, which is subdivided into intravascular compartment, which consists about 25% of the extracellular compartment, and 75% of this extracellular compartment is interstitial compartment. Is a very important compartment where all these cells live, and all the cellular metabolites are put into the interstitial compartment, and cell gain all the nutrition, oxygen, electrolytes from the interstitial compartment. And the maintenance of the osmolality and the volume of these compartments are very important, and it's a dynamic process. Fluid shifts, electrolyte shifts across these compartments all the time, and this is mainly governed by the electrolyte composition of this compartment. The main cation of extracellular compartment is sodium, while intracellular compartment is potassium. Main anion in the extracellular compartment is chloride, and main negatively charged particle in intracellular compartment is protein. And the fluid transfer between the vascular compartment and interstitial compartment is mainly governed by hydrostatic pressure, that is the blood pressure at the capillary end, throughout the capillaries and the venous end, how we sort of the pressure in the capillaries is called hydrostatic pressure, which vary from the arterial end to the venous end, and the capillary permeability, and the oncotic pressure which is exerted by proteins, mainly albumin in the blood. And the net filtration pressure is the one which sort of, there are certain forces draw fluid in and certain forces draw fluid out, and the net filtration pressure is the one which draws out going fluid. And in addition to that, the main way fluid gets back into the vascular compartment is lymphatic, through lymphatic channels from the interstitial compartment to the vascular compartment. Fluid shifts from interstitial compartment into the cells is governed by the osmotic pressures and the special channels, aquaport channel, and the distribution and the function of these channels are different in different tissues because mainly for their function. Then we discussed about now regulation is further fine-tuned when there is additional load from outside or when there is a depletion. Is controlled by other neurohormonal mechanisms and kidneys, and they are baroreceptors, volume receptors, or osmoreceptors, and the renal mechanism. Then we talked about what happens when we drink 1 liter of fluid or water, right? And we realized that water intoxication is very unlikely if someone is not forced to drink. So the best way of getting fluid into the body is to gut. But in clinical practice, we use the intravenous compartment because that is the only compartment where we have access. We don't have access to the interstitial compartment or intracellular compartment. Even if we want to replenish or get fluid from those compartments, we have to come through the intravascular compartment. So then we discussed what happens when you give 1 liter of normal saline. It is crystalloid, which is isosmolar with the osmolarity of all these 3 compartments are similar, 290, 600, 300. So if we give isosmolar fluid into the intravascular compartment, they distribute only in the intracellular, intravascular and interstitial compartment and not in the intracellular compartment. And distribution governed by the percentage of volume in these 2 compartments. So 25% in intravascular and 75% in the interstitial compartment. Whether you give normal saline or Hartmann solution. But we learned that Hartmann solution is more physiological than normal solution because of its electrolyte composition is more similar to the extracellular compartment. So extracellular compartment, if you want to hydrate or give fluid, we can give normal saline or other tissues. Right? So next day, we will talk about what happens or how are we going to give fluids into the cellular compartments. Right? Now this doesn't work into the cells. And what happens when you give 5% dextrose, which is also commonly used solution in the practice. What are the colloids? How does it work when you give intravascular? And further, we will discuss about clinical, different clinical scenarios. Dehydration, hypovolemia, how should we precipitate, and what is the physiological basis of giving fluid? Normal saline, Hartmann, blood, volume expanders in these conditions. So this will conclude the anything to be added? Any questions? Any questions from the audience? they have understood everything. Took years for me to understand. Okay, thank you. Are you still with us or you have already left?
Still here. But that was really interesting, and I'm certainly, and I'm sure the rest of the department are very happy to get involved, because this is an important message to the students as well, because we continue to learn, and although we have taught you before, there's a lot that we can learn from each other. So it's always useful to get involved with clinical teaching sessions as well. So yeah, I would be delighted to be involved.
Thank you very much. Students, any questions?